With further ado, let's go ahead. Thank you very much. I'll hand over to Suzanne.
Okie dokie. So next slide, please there, Niall. Okay, so I'll let Gillian introduce herself.
So hi, I'm Gillian. I'm Gillian McCabe. I'm a specialist pelvic health physiotherapist and I'm based in Cardiff in South Wales. And I have been using Maple for quite a while now. I think it's around about 5 years. I've got a little message saying sound is quite low. I don't know whether that's our mics, if I turn mine up. Is that any better?
Yeah, you're louder now.
Oh, brilliant. There we go. Let's do that then. So yeah, I've been using Maple for about 5 years and I've been a trainer for the last 10 months, something like that. And I will be there on Saturday to help Suzanne with the practical side of the training as well. And I run a private practice. I run a pelvic health private practice in South Wales and also a health and wellbeing centre, which is a multidisciplinary team effort. So that's enough about me, I think. And I'll move on to Suzanne's slide.
Okay. So this is me. An awful lot of you probably already know me. I'm a specialist in pelvic health as well. I did my undergrad in physio in Manchester and then I kind of worked in the NHS for a while, started to get health and then moved to Australia. I did my master's in continence and women's health in Australia in Perth at Curtin Uni, and let's just say blood, sweat and tears went into getting that piece of paper. And then when I came home, I was working in the HSC for a little while and I opened a private practice as well. And when my little girl was ready to go to school, I just went full time in my private practice. And I can't say I'm sorry that I'm not in the HSC anymore. I have been using the Maple only since this year, but I have to say I have definitely fallen in love with it. As Niall will tell you, I was very skeptical. I was very dubious about it, to be honest, at the start, because it promises all these wonderful things and you kind of think, I'm not so sure. But in practice, it has been shown like really good results for all manner of patients and all manner of presentations. I've been using it on myself as well, so I can say firsthand I have noticed a difference. But we can go through more of that on the practical day on Saturday. So pop on another one there, Niall. And go again. Okay, so why is the Maple different? Well, I suppose in short, it's 24 electrodes rather than like maybe 1 on each side or 3 on one side or 4 on the other side. It's unipolar, not bipolar, and I'll explain that a little bit more in a second. But the biggest thing is the specificity of our findings over more than one muscle. So by putting the probe in and getting the feedback back through the iPad on the app, you can be so specific about what you find and then target your treatment towards that much better than if you were just popping in the regular periform probe. Okay, so go again. So if we were just measuring bipolar over one muscle, that would be fine, but we can't really do that in the pelvic area. It's just not possible. So what we end up doing is, go to the next one, actually doing bipolar measurement over multi-muscles, but unfortunately this isn't very valid. There's a lot of disadvantages to having a bipolar probe. You're not able to specify the muscle you're measuring, you're not able to select specific muscles while you're measuring them, you can't get a 2D image of the pelvic floor, and I think this is probably one of the most important ones, you're not able to identify asymmetry within the pelvic floor. So your pelvic floor is a combination of 12 muscles working together, left to right, front to back, and they're innervated really differently. So when you're using the bipolar probe, you only get an average of all of that. But with the Maple, you can really get specifics for each individual, whether it be front to back or left to right. So for that, I really, really like it. Also with the probes, you can see they come in all different shapes and sizes. So kind of standardization between them isn't fabulous. And sometimes, say the wider ones, when they're going in, they can actually stretch the tissues a little bit, which doesn't give you the most reliable measure in the world then in the end either. Also, you can't measure the external anal sphincter with these probes. So, you know, for so many people, they have fecal incontinence, platal incontinence, and we can really target the treatment of that with the Maple probe more specifically. So pop on another one there, Niall. Okay, so the Maple then is a unipolar probe with multi-muscle measurement. We have our reference point at the top there, and that usually goes on to a bony area, so like the ankle or the knee, and it's just one of the little sticky electrodes that you'd see like for cardiac measuring. The reason that this is really good is that it's quite small as well, like it's only the size of your finger. So when that goes in, either vaginally or rectally, it's not stretching things, it just keeps everything in kind of the normal anatomical position of that person. Whereas, and for that reason then as well, each of those dots of electrodes are on each individual muscle, whereas say the piriform has the large electrodes on it, so that's getting measurements over a number of muscles at the same time. What else did I need to say about that? They're the main things. Did I miss something about that, Gillian?
So the only other thing would be the reference point gives you an absolute 0.
Oh yeah.
So with the reference point, you have a little EMG electrode that sits on a bony prominence. So usually the kneecap, sometimes the medial malleolus, but that is on an area that doesn't have any muscle activity. So what you can do there is compare your muscle activity on each of the 24 electrodes with 0. So you can find an absolute 0, and then you can be really sure that the EMG findings in that muscle are correct and valid.
Yeah. See, it's not our first rodeo. Okay, now you can move on another one. Okay, so this is what I find really cool. It's very interesting. So the way they've developed the grid to bring them what they find from their circular probe back onto a 2D image is really clever. So as you can see, you're inserting the probe in vaginally or anally, and then they have like created a box, and each of those colored boxes becomes one of the quadrants. So when they open the box, they turn it around and they make it into a 2D image, and then they put in the lines to make the grid. So it works really, really cleverly for standardization for research. The way it attaches onto the lead as well, there's only one way you can put it on so that it connects correctly, so you know you're doing it right, and that no matter what way you put it in, the orientation of the lead coming off it tells you that you have it in the right position, so you know exactly that the results that come back onto the iPad are the right muscles that you think you're working on, so you can target your treatment really, really well. The way I kind of explain it to patients is that, like, say the red part at the top would be, imagine your pubic symphysis is up there, and then the green part at the bottom underneath that is your tailbone, and then you have left to right, and on the screen you can flip it to make it patient view or therapist view, and then I say, okay, imagine that white circle in the middle, that's where we pop the probe in, and they're like, oh yeah, I get it, yeah, totally get that. So the way that it's displayed back to you as a clinician is really, really easy to understand, but also for the patients, they love to see it and they can really understand it, rather than like mad bar charts and line graphs and stuff that really don't give them much information as a lay person. So you can pop on another one, Niall. So there should be a way to play a little video there, Niall, hopefully. If you hover over it, there should be a play button. Maybe not. Maybe it won't work when it's doing this. But basically what we're looking at is the outer rings are kind of the most external parts. So if you look at that outer ring, we will be saying that's the how would I say it? The kind of the most external pelvic floor muscles, and then the further in you go, you're getting closer to the deeper pelvic floor muscles, and each of those rings you can see on the grid corresponds to a circle of rings on the probe. Again, this will become way clearer on the day on Saturday when we actually show you it in action. Also, if you see the narrow part at the probe there at the bottom, that narrows in, and that is really good for giving us kind of an indication of what's happening at the external urethral sphincter, particularly when you're measuring vaginally. And that's something we didn't have at all on like the current probes that we were using for our other machines. So I like that as well. It's really quite specific all the way from like deeper to superficial. But there was a lovely video there that's not going to play, so that's fine. We'll move on. Okay, so this is really good as well, because we know from this study that was done in the Netherlands that things have been validated with this probe. So you can see, where did I write it down? Yeah, so it was done in the Netherlands, and there was 229 people scanned using the probe in the MRI. Each of those were healthy individuals. They had no pelvic floor issues. There were male and female. There was a wide variety of ages. And by compiling all those people together and getting all that data, based on the images they got back from the MRI, they were happy to say that yes, the probe lay on X, Y, and Z in these points, and it was consistent for everybody. So they were able to then use all that data to then program it into the Maple to make it, you know, that's what created the probe. So they were able to say, yeah, definitely our product is very reliable and quite sensitive in the areas that we want it to work in. You can see as well, like it does kind of hit the tissues quite well. Like a lot of people would say, oh, you know, it's probably too narrow to actually give you correct information. Maybe the bigger ones are better. But when you see it in situ in the MRI, like it is in close contact with the tissue. So when everything was being developed in the Netherlands with Novaquire, they're happy with the probe that they created. Now, the probe that we have is not the very first version of the probe by any means. They've been working on it, and it's been upgraded and refined so much. But the one that we have now is pretty good. Don't think I need to say anything else about that study. You can move on.
Sorry, can I just mention something? Yeah. The other thing with that study is that the only time that it's not validated in terms of the position on the muscles is when you're dealing with major prolapse, vaginal prolapse, or rectal prolapse. So if obviously you've got a grade 3 prolapse and you're repositioning tissues with the probe to be able to do the treatment, you can't then be absolutely sure which muscle you're on. But outside of those scenarios, you can be absolutely sure that certain rings and certain plates will correlate with certain muscles. And you'll find out more on Saturday as well.
Yeah. Okay, so we'll just have a quick look at how like we actually measure stuff with it. So the EMG function of it. So if you pop on another one there now. So basically, what are we measuring with it? So we're looking at myoelectrical activity, so neuromuscular function, and motor nerve activity. Now we know that the pelvic floor is mainly innervated by the pudendal nerve, but also branches of the S3 and 4 sacral motor nerve roots, like the levator ani nerve. This will not tell you, the probe itself or the Maple will not tell you about movement or strength or pressure. So we can't discount our basic assessment skills with our hands, doing a digital examination, also based on the subjective that the person gives us. Like, this isn't the first line of treatment I would give any of the patients that I've seen so far. Like, we go through all the other basic physio stuff. But I suppose Meryl, the lady that I did the first training I went to in London with, she said, and it made a really valid point, our finger just is not sensitive enough to say specifically that's iliococcygeus that's moving or pubococcygeus, whereas this can then inform us so much more to really give us a really complete picture of what's going on for that person's pelvic floor. Also, I have been really surprised when I've done the scan on somebody and I think, oh yeah, this is what I expect to find, and then when it comes back I'm like, oh wow, actually your resting tone is really high, or you know, it's a real learning curve with it as well. So I'm learning stuff every day from it. So you can pop on again, Niall. Okay, so we do get a line graph back from it. And one of the things that we start off with is just getting 3 lots of basic measurements. So of course, in anything physiotherapy based, you want to have an outcome measure. You want a baseline measure so that then you can do your treatments and go back and remeasure so that you have consistency and you have the ability to say, okay, well, this is deteriorated or this is improved. You know, that's just the nature of what we do. We want to see progress. So there's 3 things that we look at. The first one is rest. So we get the person to, you set them up, you insert the probe, and you say, okay, right now, 60 seconds, no talking, no moving, no squeezing the pelvic floor, no trying to be the perfect patient, just lie there and do nothing. And we get a measure of what's happening at their the electrical activity of the muscle at that point. And by God, is 60 seconds a really long time when you tell the person that they can't talk, or that if you're a chatterbox like me, it's really hard to stay quiet. The next thing then we look at is their maximum voluntary contraction. So it's a 3-second squeeze 10 times, and then they have rests in between. So that's what we're looking at there on that little graph. So we're getting them to squeeze and like go and rest, and then squeeze and go and rest, and then we get an average measure back of those. And then the next is the endurance. So we get them to do a 30-second squeeze with a 60-second rest, and we do that 3 times. And all of that, then you can store that on the app on the iPad so that you can say, okay, this is what we found, and I flick it around and I show it to the patient and explain what we found. Also, there is the function that if there is an element that you think is like you and off the measurements that you get. So like personally, when I did my measurements, like there's a part of my pelvic floor that is up to high dose. I have no idea that it's doing it. And at rest, I thought everything was relaxed, and clearly it wasn't. And so we were able to eliminate out that part of it and then redo my resting measurement to get like a true idea of what was going on with the rest of my pelvic floor. And so you can really make it specific and play around with it. Then there's the training function as well. Like you can use those things for biofeedback. You can show them on the screen, the squeeze and release, but that's not recorded. But that's what they're the images we get back. So it's really nice from that perspective. Anything else, Gillian?
With the training, even though it's not recorded onto the app, you can use your iPad to do a screen recording, or you can take screenshots and then you can upload that. I use an online system for my client notes, so I tend to upload screen videos for anything that's really useful, anything that they struggled with, anything that they really they were victorious in. I'm trying to think of the word, but they achieved a goal. Then I'll record that, and then I might send that off to them on email as well, just for their own motivation's sake. So even though it's not recorded on the app, you can record it from the iPad with screenshots or screen recordings.
I haven't done that with anyone yet. That's a good idea. Okay, you can pop on to the next one, Niall. Okay, so just getting like what we expect to be your normal values at rest. You can see that on the bar chart there's a green line, and that reflects what we would expect from a vaginal insertion. So we would expect 0 to 2 microvolts or 10% of max contraction. So that would kind of be like your baseline resting tone, where if it's at 0, there's a problem. If there's no electrical activity whatsoever, then we wouldn't say that person was too healthy. And then anally, we say anything up to 0 to 4 is okay. The reason for that is just because the nature of where the probe sits in proximity to the tissues anally is a little bit tighter than it would be vaginally. Say when I did my first assessment, my resting tone came back at like 12 microvolts, which was outrageous from a resting perspective. But then when we eliminated out the part that was overactive, it brought it back down to like 1.9, I think. So it brought it back into that normal range. So then I knew I had an area that I needed to work on to kind of down train, that there wasn't actually anything significantly wrong with the rest of my pelvic floor in terms of strength. So it's really good to know what your baseline expected measures should be. Okay, off you go now. Okay, so how to read it then. And we're looking at onset to offset time. So the onset is the time taken from rest to maximum contraction. So you can see that there from the blue, circle up to the red circle, and then your offset is from the red circle down to the green one. So that's the time taken from max contraction to rest. And the normal range for that is within 1 second. Definitely in the patients that I've been seeing, I don't think that they have that. It's much longer, particularly in the ones that have like more of an overactive pelvic floor. The let go for them, it takes much longer. And also, I think maybe as time goes on, and I've seen patients a few times and I've been redoing their measurements as we go along, they nearly know what I'm going to ask them, and they start to preempt the squeeze, or they're even like 3 or 4 squeezes in, they're nearly preempting the next ones to come on the first day. So, you know, kind of giving them really clear instructions is really important to get really precise measurements. And Gillian and I spoke about this before, like in terms of maybe doing some research down the track, we need to, if we are going to all do that, we need to try and keep our cues really standard, and like how we describe things really standard, just, you know, from gathering evidence from multi-centers. But yeah, it's just to get the patient on board with what they need to do. But overall, that's just what we need to look at for their onset offset. Okay. Anything else on that, Gillian?
No, that's everything for that.
Yeah. So, okay. So on the scale itself, on the leaflets, you'll see these beautiful red and blue images that look very visually appealing, but they're not really what we would use in clinic day to day. So the absolute measurement is the gray scale, and that is basically where you really get your diagnosis. So if you have a white 0, you have no activity, and then if you have up to 16 plus, you have really increased muscle activity. Whereas the blue and red one, that's actually based against healthy volunteers. So 0 means that you are equal to the reference group. Red, in any like pink or getting into red, means that you have more muscle activity than the reference group, and blue means you have less muscle activity than the reference group. So really that doesn't tell us much on an individualized basis. Meryl said on her teaching that really the only time she kind of used the red and blue was if a surgeon was asking, did she think that the person was ready for surgery, she could flip it over to the red to blue and then kind of see where her person was in relation to healthy volunteers. And she said if they were white or red, she felt that their pelvic floor was good enough for surgery. And then if it was blue, she'd be saying maybe we do a little bit more therapy, get them in better shape, and then they'd have better outcomes from their surgical intervention. So for that reason, it's pretty good. But on a day-to-day basis, I actually just use the gray scale. It gives us more individualized information about what's going on for the person. Anything else, Gillian?
No, that's everything for that.
Okay, Niall. Okay, so that's pretty much telling me what I've already just told you. But yeah, there's nothing else. So I suppose the other thing is that it's myoelectrical activity. I suppose how we describe things, we're not describing strength, we're not describing power, it's the electrical activity in the muscle itself. And I suppose that's important to remember as well when we're describing things and talking to patients about it. Okay, now. Okay, so this is looking at the grid a little bit in more detail. So you have anterior at the top, posterior at the bottom. You have right to left if you're looking at it from therapist view, but you can flip it around and make it left to right for patient view. And you can do that on the iPad. So we have rings and we have sides. So this is where we have to keep standardized as well. Like we all need to say that ring 1 is ring 1 and that ring 6 and all the rest are the same. Otherwise, if we're looking at data when it comes out, it's going to be very confusing and it won't make sense. So ring 1 is your central ring, ring 6 is your outer ring, and then there's 4 electrodes in each ring. So if you look at the electrode, there's 1, 2, 3, 4. And then sides wise, we've anterior, posterior, right and left, and there's 6 electrodes in each side. So that would be 1, 2, 3, 4, 5, 6. And it makes more sense when you actually see the probe. Sorry, it's getting very dark in here. The other thing about that, yeah, I've said that you can flip it over for ease of communication. Sometimes that gets a bit confusing as well. I think I'm a bit dyslexic with my left and right, so often I have to nearly think about, okay, what's this showing me versus what's going on with the person in front of me and what do I actually need to treat. So taking your time to think about it and kind of clinically reason it out in your head is really important. Like, I'm still very much learning, and the patients that are using it with me know that. I'm by no means an expert on it, but they're so excited to use something different and unique as well, that they're like, okay, that's fine. What's going on here? What else are we going to do? So you can flip it on there now. Okay, so then we get these lovely images, and if you purchase the Maple, you get like a user handbook with all these things in it. We'll probably be able to give them to you on Saturday as well. But this just kind of gives us an indication of what is going on vaginally first at the grid that you get back. What are we actually looking at? So we would say that bulbospongiosis and ischiocavernosis are rings 6 and 5, right and left. And I have this printed out in and laminated, and I have it like with my Maple so that I can, when I look at my thing, because it doesn't actually tell you what muscles are on your app, but I have it there to use to really clinically reason out stuff. Then if we ignore the light blue ones for the moment, then if we move down to puborectalis, they're rings 3 and 4, left and right. And then pubococcygeus and iliococcygeus are rings 1 and 2, left and right. Then there's lighter blue for the urogenital diaphragm, excuse me, and the anal canal. The reason that we have the dark blue is that we know that those muscles, we can say specifically based on those MRI reports that yes, these are the muscles we're working on based on the MRI and where the probes are lying. However, with the urogenital diaphragm and the anal canal, we run into a bit of bother because we have a wall in between. So there's a wall between, so the anterior vaginal wall restricts kind of stuff to the diaphragm, and then the posterior vaginal wall is a little bit of a barrier to the anal canal. So the light blue, say in the urogenital diaphragm, we would say external urethral sphincter and compressor urethrae lie there, but we can't say specifically what rings they are on. The same then in the anal canal, we would say that the external sphincter lie in that compartment, in that segment, but we can't see what rings they are. Does that make sense? You can't respond. If there's any questions about Saturday, we'll go over it again loads, like it'll make way more sense when it's put into practice. Okay, then if we move on to the next file. How are we doing for time? Okay. So this is looking at an anal insertion. So this is a little bit different again, but the principle is exactly the same. So the rings are the same, the sides are the same, the plates are the same, all that sort of stuff. On the outer ring, so on ring 6, when we do an anal insertion, we say that's the external anal sphincter. Then puborectalis, we would say, lies in ring 3 and 4 on left, right, and posterior. Then pubococcygeus and iliococcygeus lies in rings 1 and 2, left, right, and posterior. So we can say, right, definitely we know from the MRI this is where they lie. We are missing ring 5, and for the life of me, I can't remember why, Gillian.
Sorry, say that again.
We're missing ring 5 anally. What that's to do with smooth muscle, isn't it?
Yeah, well, what that's to do with is ring 6 is definitely external anal sphincter. Ring 5 will be a mixture of the external sphincter and the internal sphincter, but the internal sphincter is smooth muscle, and the EMG won't pick up smooth muscle activity.
Yeah. So that's as well, like, it's really important to note that it's only skeletal muscle activity that we pick up, not smooth muscle. So when we look at the urogenital diaphragm / vagina on that anterior part, it's even trickier in this sense, particularly in a woman, because there's now 2 walls that the Maple has to try and pick up electrical activity through. So it has to go through the posterior wall, the vaginal cavity, and then the anterior wall to know exactly what it's picking up. we would say that in females, in an anal measurement in that anterior compartment, the levels picked up will be lower than in a man, and that's simply because there's two walls rather than one wall that needs to be traversed to get a reading onto the probe. But yeah, it's like once you get into the hang of it and you kind of get going with it, it is quite straightforward. And I've had I have to say, really good results with a few men with the anal insertion that are like post prostatectomy, you know, significant leakage, and they've done really well. Now, they were allergic to the thought of a probe going in anally initially, but once they got over it and I explained the benefits of it and everything, they were fine. And the first time was always the hardest, but they've done really, really well. I was quite surprised by that. So they've done really, really well. Okay, moving on, Niall. Okay, so you get all these lovely graphics from Maple and NovaQuire when you get your device. So they're just like little cheat sheets. They're really, really handy, and they kind of help you to clinically reason out what's going on. So they're saying, okay, what can you see on the graph? What can, like, use your physio head. And if nothing else, I would say this device has really made me work on my clinical reasoning, because you nearly, I suppose we fall into patterns a little bit when we start treating patients. But when we get this and it throws up a little bit of you know, a red flag, or it kind of throws up a little kind of spanner in the works, like, okay, right, what is going on there? So it's really made me clinically reason out what I'm doing and my treatments for certain patients anyways. So what can you see on the graph? What can you see on the grid, and where can you see it? And then what's that relationship between the rest, mean voluntary contraction, and your endurance? And then when you think about your treatment plan, how do you link those observations with the symptoms that the person has presented with in front of you, and what muscle dysfunction or function do you want to improve? And I think that's one of the things that really sold this to me, that it wasn't all about like tightening and strengthening and lifting and weak pelvic floors. Like, there's elements of down training overactive pelvic floors, which is hugely important, and I see more and more overactive pelvic floors all the time. There's an element that can be dealing with pain. You know, it's not just about pelvic floor strengthening. It's not a one size fits all device at all. Okay, now you can move on. Okay, so you get your protocols as well. So all of this comes, and this I think is really good that we stick to it if we are going to do any kind of research in the future. So it gives you the application settings for rest, max voluntary contraction, and endurance. So it tells you exactly how many squeezes you have to do, the rest, how long you need to rest for, how many repetitions, all that sort of stuff. And then it gives a really kind of standardized spiel of explanation that you give to your patient. So it just it keeps everything really, really standard. And for me, who's a real chatterbox, and I have a very colloquial way of describing things sometimes, this keeps me on track. And then an instruction during the test as well. So again, to keep it standardized, that you're not deviating off, it gives you like relax, another 30 seconds, relax for your rest, and then your max voluntary contraction, tighten, release at a speed of 21, 22, and then tighten, hold, another 15 seconds, hold, release. So it really keeps it really standard, which I think is great. And I know we haven't put it in here because it can be really theory heavy. Out of all the devices that are available at the moment, whether it be the Maple or Peritone or like all these pelvic floor training devices, an awful lot of them have actually gone to market with very, very minimal research or evidence base behind them. Whereas this has got evidence behind it, and there's it's not all been, you know, what's the word, subsidized or paid for by NovaQuire. Like, there's been independent research done on it as well, which is really, really good. So there's no bias with that. Okay, moving on, Niall. I think I'm nearly done my section. Aha, yes. On to the beautiful Gillian, who has saved the day.
Aha, well done. That was really, really clear. Before I start my bit, clinical discussions and case studies, has anybody got any questions? You can pop them in the Q&A or in the chat. And while I'm chatting, I'll have a quick look across. So if anybody does have any questions, or feel free to bring them with you on Saturday, we're more than happy to answer questions there. but I think that was pretty clear. Thanks, Suzanne. So next slide, please, now. Okay, so in your Maple booklet or handbook that you get when you've purchased the Maple, you will see this information here. And this is your biofeedback guidelines, and this is what you're looking at. I think Suzanne just went through a lot of this in terms of what you do for the rest assessment, what you do for the maximum voluntary contraction assessment, and what you do for the endurance test. For a lot of people starting off with Maple, just a quick note, when you're looking at the endurance, 30 seconds seems like a long time, and it feels like a really long time, especially if you're chatty like myself and Suzanne. But it's really important that you do try the 30 seconds because it does tell you a lot about what the patient's muscles are able to do or not able to do. So making sure that you go through the endurance to the 30 seconds and give them the full 60 seconds rest in between. And it's important then that you factor that into your treatment times, because if you give yourself, say, half an hour for a Maple treatment, you might find that you're cut short and then you're tempted to say, oh, let's just do a 15-second hold and a 30-second rest, but try to make sure that you keep it to what Novacare have advised. Okay, so next slide, please. All of that would be in the booklet. So we've got some case studies here. Now I know you haven't tried Maple, but we've got a grid and we've got a graph here. And this lady is female, age 40. She's had 2 pregnancies and 2 deliveries. Her main symptom is bladder leakage postnatally. She had no problems antenatally. And she had leakage with any movement. So anytime she was upright, whether she was walking, coughing, sneezing, lifting, pushing, pulling, there was some level of leakage. The greater the pressure in the abdominal region, the greater the leakage, and the greater the volume that was in the bladder, the greater the leakage as well. Her main aim was to return to running. She used to be sort of a 10K to half marathon runner prior to childbirth, and she wanted to get back to at least a 5K 3 times a week. So when we're doing our clinical reasoning, and we're going to be doing this a lot on Saturday as part of assessing the pelvic floor, we need to go through a simple process of what do you see from the grid? What do you see from the line graph, and how does that change during rest, MVC, and endurance? But on this case study, we've just got the MVC grid and the MVC line graph, and you can see basically what that patient is able to do on that session, which was back on the 15th of December 2020. Okay, so first of all, what do you see in the grid? So what I can see is there's not much in terms of the dark coloration. So you can see the grayscale from 0 to 16 on the left of the grid. When we're looking at the MVC, it's the summary of all of the squeezes. So you have the 10 squeezes, and within that 10, every single peak EMG score, so the maximum microvolts that muscle has been able to produce, is summarized in the grid at the end. So you can see just underneath the grid, it says overall. So that's the summary of the squeezes. And then in the arrow next to it, you can scroll through for each of the squeezes. Now in this one, this was when I was very new to Maple. You can see I've only done 5 contractions there. They were active for 2 and resting for 5, which is outside of what Novacare have suggested as being the standard. Obviously that's been changed since I've practiced, but it's useful to know that obviously you can change it, but for testing and saving it, you want to keep it the same. But on that grid, you can see there's not many dark colours in any of the rings. And you can see that the middle section is fairly light. You can see that there's not really any area that's working very hard. So we are looking on that grid at a fairly switched off pelvic floor. So looking at that pelvic floor and then combining that to what we see in the graph. Within the grey sections of the graph, the blue line should be rising up, ideally to around 16 to 20 or more vaginally. But you can see there, her peak score is 4.6, her average score is 2.3. That's really, really low. So this pelvic floor needs CPR basically. It's not working very much. So we would be looking at probably electrical stimulation to get things going. And then once you've got things going, then EMG biofeedback to improve the connection and the activation. So my overall impression is that it's a really switched off, disconnected pelvic floor, and that links in with what we're seeing in her symptoms of being upright, moving, any increase in intra-abdominal pressure causing bladder leakage. So it makes sense. So with the treatments, then we can start to clinically reason and plan the treatments into electrical stimulation or biofeedback. So hopefully that's clear, and we'll move on to the next slide. Okay, so here we have a prolapse case. So this is again a female aged 40. She's had 3 pregnancies and has 2 live births. She's had vaginal prolapse following the 2nd childbirth. She had long 2nd stage von Tu's delivery, or attempted von Tu's, then forceps, and ended up with C-section. So she had quite a traumatic time of it at delivery. She was normally very active, and she'd lost her sense of identity and felt very traumatized from the delivery. And she was very fearful of the progression of prolapse, which I'm sure a lot of you are very aware of in your clinics. A lot of patients coming in with prolapse are very fearful of the future. So here now we've kept with the MVC findings. So we've got the grid on the left and we've got the line graph on the right. And you can see it's quite a different picture now compared to the last case study. So with this here, we can see that on the grid, we've got some darker grey areas and we've got some black areas too. Now with the MVC, we want as many black areas as possible. You don't need to aim for a complete blackout. You're not aiming for that, but as many black or dark grey areas show that there's a difference between rest and squeezed. So here you can see that the majority of the activation is in the deeper pelvic floor, so rings 1 and 2, anterior less so. But remember, anteriorly, you are looking at different structures as well. So you've got the bladder wall, you've got the urethra, you've got the urogenital diaphragm, you've also got the external urethral sphincter as well. So it's less of an issue if you don't see so many darkened colours at the front there on the anterior plate or side. The right side looks more active. So that's actually on the left of our screen. Okay, so that's in therapist view rather than patient view, which Suzanne was talking about. But the right side is showing a lot more activity than the left, which is interesting because she didn't have episiotomy. So there was no episiotomy. There was attempt of forceps and von Tu's ended up in a C-section, but no episiotomy. So there's no trauma to the pelvic floor, no scar tissue, but you can see that there is asymmetry. And what we would be looking at is ring 3, 4, and 5 on the left side are less active, as is posteriorly ring 5. So we're looking there mainly at puborectalis and puborectalis and a little bit of bulbospongiosis on that left-hand side. And the asymmetry may be where there's thinning of the muscle and less activity on the left-hand side, which is allowing a pelvic organ or vaginal tissue to drop down. So it would be important in terms of treatment to build up the symmetry. And you would work with this lady to improve maybe her connection. So you could talk to her about visualizing activating the left side completely. So using visualizations, using a change in positioning, maybe dropping her left leg out to the side to increase the anchor point through the connective tissue and the fascia on that left-hand side, and using biofeedback to help her see if she's able to activate the left rings 3, 4, and 5, or you could use electrical stimulation, which we'll talk about again, to try and activate rings 3, 4, and 5. So you could specifically use the stimulation, which we'll talk about again, to stimulate that slightly less active area. But what's interesting here is if you didn't have the grid and you only had the line graph, so say with a lot of the EMG devices that are available out there, the bipolar devices, you would be looking at the line graph and thinking, I don't know why this person has the symptoms that they do. And you would be much more reliant on your manual techniques for assessment, because actually on the graph, she is getting between the 16 to 20 microvolts, and it looks like she's got a really good onset and a really good offset. And there is a little bit of work to do with that, but majorly she's able to squeeze and release at will. She's able to do it on command, and she's able to do it to a good level. So those squeezes do actually look really, really good. But when you combine that with her symptoms and you combine that with the grid, this is where Maple comes into its own. You can see the asymmetry. You can clinically reason why she may have those symptoms of prolapse and the asymmetry causing that potential drop on the one side of support. Then potentially that will help you to give more bespoke and effective treatment options. So hopefully that helps to show you how Maple can be really useful. Let's go to the next slide then, please, now. So here now we have the anal insertion of Maple, and you can see here a really common grid view as a summary. So you've got the 3 grid view that you will get at the end of every full assessment with Maple. And this is what is saved onto the patient's file on the iPad. On the Maple app. So the leftmost grid is rest, the middle grid is MVC, and the right-hand grid is endurance. And then we've got the line graph as normal above, but there we're looking with the line graph at the endurance. Okay, so remembering this is anal insertion. This is a female age 69, and she's had 4 pregnancies, 4 deliveries. Her main symptom is fecal frequency. She has loose stools, which obviously links in with the fecal frequency. She relies on Imodium. When I first saw her, she was using 8 Imodium tablets every day. She also had fecal incontinence, mainly associated with urgency. And her main goal was to be able to go to choir practice, to sing and to go out and socialize as part of that practice without the fear of leakage or having to rush off to the toilet. So again, we're doing the same thing. What do we see on the grid? What do we see on the line graph? And how does that all add up? So if we start off on the line graph, we're looking at the endurance here. So it's a longer hold. And with this longer hold, we are looking at a pretty good ability to squeeze and hold, but maybe not as strong as it could be. So you're looking at about an average of 10 microvolts for the hold, whereas ideally, especially anally, it should be closer to the 20 mark or even higher. You can also see that in the rest period between the 2 grey boxes in that white section, she's not fully relaxed. And there are points there where she's getting some peaks and possible spasms, which may well be a sign of she's not able to release, or maybe a sign of tiredness and fatigue related spasm in that rest period. You can also see on the far right of the line graph a very large spike of blue. And I've left that on there because that is a bit of interference. So that's where something had touched the wire, so it might have been my hand or her ankle, and it caused a little bit of interference. And you can see there that there's a spike there, and that went up to, I think it was 120 microvolts or something like that. Now it doesn't matter in the rest periods because we're not recording the rest, we're recording the squeeze during the endurance. But if you do get that during the recording, so within the grey boxes, that will skew your results. So you'll need to stop and start again. It doesn't happen very often, but when it does, it's usually human error. So it's either something's resting on the wire, say her ankle or her knee or something like that, and you just need to reposition everything to make sure there's no interference. But once you get used to, oh, that's what it is, it's much easier to then move things around and start again. Okay, so what do we see on the grid? So the first grid on the left, we are seeing a pretty good overall resting activity. So the resting activity is 2.0 microvolts, and anally we know that it should be 0 to 4. Or 10% of her maximum, but she's 2 microvolts. So overall it's fine, but within the grid, you can see that on the right and posterior and a little bit on the left as well, there are some slightly darker grey areas, and they are in rings 3 and 4, which ties in anally with puborectalis. And sometimes you'll notice that puborectalis will overactivate to try and hold on to stool if someone has had any urgency or fecal incontinence issues. And that basically will be a response to the symptoms. So what we've got to make sure is that we just keep an eye on that. It doesn't look as if it's dark enough to warrant any treatment. But another thing that we can do is we can filter out the rings. So we can just look at what's happening rings 3 and 4, and we can do that all the way around the rings, or we can filter rings 3 and 4 to the right and the left, and we can practice that during our sessions on Saturday. But when you filter it, the summary or the average of that electrical activity will be specific to one muscle, rather than looking at the summary of the whole pelvic floor and sphincter complex. So you might then be able to zone into rings 3 and 4 and notice, well, actually, when we're looking at puborectalis in particular, the electrical activity may have gone up to 7 or 8, and we know it's more of an issue. So you can have a wide angle view and you can zoom in, and that will give you a lot more information about what's happening in each individual muscle. And I have to admit, I use that a lot with my anal patients now, because we need to know the difference between what's happening in puborectalis and what's happening in the external anal sphincter, and to see the difference between the two there. So that's just a point of interest there. But her resting tone is pretty good. The other thing, I don't know whether you can see it there, but on rest and ring 1 on the left, it's white with an X in the middle, and that's at rest and MVC. And that just means that there's not enough gel contact. So you need to put a fair amount of gel on, and if there's not enough gel, you will get that sign, and it won't measure anything in that specific electrode. You can take the probe out, put more gel on, put the probe in, or you can move the probe a little bit, see if that helps to spread the gel around onto the electrode, and check again. But if it's just the one, then in one sense, you don't need to worry. Okay, so moving on to MVC, so the middle grid. And obviously, remember, with MVC, we're testing the activity rather than the resting activity. We're looking at how her muscles are able to increase in activity. So here you can see there's good activity in the right side, rings 2 and 3 and 4. And on the left side, rings 2, 3 and 4 again. And then posteriorly, you can see rings 4 and 5 are activating pretty well. But there's very little change in ring 6, which is the external sphincter. And when we're talking about fecal incontinence and fecal urgency, you need to have a functionally active external anal sphincter, and you need it to be active quickly and on demand. And we're not seeing that function here on the grid. So even though on the line graph, the activity might look weak overall, or not weak, I shouldn't say weak, underactive overall, but is working. With the grid, we can be much more specific, and we can see, well, this is what's happening specifically in the external sphincter. And you can zoom in and just test the external sphincter when you're doing the MVC. So again, you can do the wide angle view of the whole grid, and then you can filter out and just look at ring 6, ring 5 and 6, for instance, and then you can see the difference in activation and the difference in ability, and you can show that to the patient as well. So you can say, look, when your pelvic floor is involved with your sphincter, your blue line on your graph goes like this, but when we just look at the anal sphincter, your blue line on your graph hardly moves. We can be sure that it's your anal sphincter that's the underactive muscle, and we need to treat that. Okay, so that specificity again is where Maple shines. So moving over to the right-hand grid, again, you can see good dark colouring in the pelvic floor, specifically puborectalis. So rings 3 and 4 are puborectalis, coccygeus rings 1 and 2. So puborectalis in particular is working quite hard. And then you can see that there's a darkening of colour posteriorly in rings 4 and 5. But again, the external sphincter, although it is darker, so there is activity there, it's darker than at rest. It's not as dark as it could be. So our focus would be on improving the external sphincter, and hopefully then that will improve her urgency incontinence symptoms. And if the external sphincter is starting to pull its weight in the team, so puborectalis versus external sphincter, then as the external sphincter activity and function increases, then you should find that the resting activity of the puborectalis will be able to drop back to more of a normal level. But if it doesn't, then obviously you can add treatments for the puborectalis to relax it and to work on the biofeedback to help with the teamwork there. So hopefully that makes sense. Obviously we can go through any questions either at the end of this or on Saturday. So next slide, please, Nat. Okay, so now we're looking at the use of Maple with pain. So we have a female age 40 again, G2P2, and a 7-year history of pelvic pain, so chronic pelvic pain. She was unable to sit upright. She also had right-sided leg pain, and she was limping when walking. She had a traumatic first delivery with an episiotomy. She also had symphysis pubis dysfunction or pelvic girdle pain in her second pregnancy. And her main problem is painful intercourse, and she really struggled with having a smear test, and they were very painful. In her words, she said they were horrific. So again, we've got the 2 line graphs at the top here now. So bear in mind her symptoms. On the left, we're looking at her resting activity. And on the right, we're looking at her MVC. We didn't test endurance in this session. And the grid here, you can see the resting grid summary and the MVC grid summary. So if we start again, exactly the same, keep the same process, it'll help your clinical reasoning to fit into place. You'll get those puzzle pieces together. The top left graph is her resting activity. So her resting activity is averaging out at over 10 microvolts. So you think back to the earlier slides with Suzanne, the resting activity vaginally should be 0 to 2 or 10% of the maximum contraction, maximum possible contraction. So unless she's got 100 microvolts for her contraction, she is increased in activity. Now, when we do vaginal examinations or rectal examinations, there's quite a lot of discussion now as to whether we can actually say it's increased activity or increased tone, because we don't know what the baseline is. If someone's just come in to see us initially, we can say it's highly likely, but it's very difficult to be objective about that. Whereas with Maple, we can say, well, we've got objective measures that are within the normal ranges. So if this lady is showing 10.7 microvolts as an average resting activity of her pelvic floor, we can categorically say she has raised activity at rest within her pelvic floor. But we can go further than that as well. So if you come down onto the grid and the left-hand grid, you can see that her average is 10.7 microvolts. And within the grid, we can be even more specific. So you can see that rings 1, 2, and 3 on her right and ring 1 posteriorly are the main muscles showing overactivity. We've also got some overactivity throughout the whole of that pelvic floor. It's a much darker grey appearance than the other resting grids that we've seen. Hopefully you can see that. So this will tie in with painful intercourse, dyspareunia, due to the overactivity, painful smear tests as well. So there is a need for treatment. But in the assessment, we could also go further and filter out the right side rings 1, 2, 3, and 4. And I wouldn't be surprised if those resting activities were 16, 17, or even above, which is way too high. And obviously that's potentially something that's going on 24/7, or at least when she's upright and active, she's using that activity way too much and tiring those muscles out. So that's definitely linking in with her symptoms. So if we look then on the top right graph, we can see there her MVC. It's not really clear, but we can see her maximum voluntary contraction. Her initial squeeze, so that first left-hand grey box there, you can see a beautiful vertical blue line. So when she goes to squeeze, those muscles tighten up really, really well. But you can then see that the release is much more gradual. So it drops away slowly, and she hasn't been able to fully release by the time the next squeeze comes. She's still able to produce a vertical line on her second part of the graph, but again, the release is even harder, and her resting activity in the white section is higher again. So with each squeeze, she's only done 2 squeezes, her resting activity is really high, and it's rising before she squeezes again. And she has to really work at trying to release it off before the next squeeze comes. So her ability to release is poor, and because of that, she's losing that coordination and that ability to do the quick squeezes. So that really will tell us what we need to work on. We need to work on her ability to bring that resting activity down. We need to use treatments and biofeedback to try and help her release that muscle and to understand where it's tight. But we might not just use maple. We might use manual therapy techniques. We might use dilators. We might use therapeutic wands. All the physio tools that we've got available to us, we can use. But maple can add in really useful assessments to give you your baselines as the treatments go, and you can see what's being effective. But for me, with an overactive pelvic floor, quite often I'll do electrical stimulation to those pelvic nerves, affecting those areas, and bring that resting activity down. So if anyone on Saturday does have raised or elevated pelvic activity at rest, we can use those treatments to see what the difference is. But you can bring that resting activity down. It takes some time. Sometimes it's instantaneous after treatment, but usually you'll see the difference each week that that patient comes in. So hopefully that helps you with your clinical reasoning and how useful maple can be. Next slide, please, Niall. Okay, so I don't know whether Suzanne wants to come back in. We've got a bit of time to go through the electrical stimulation.
No problem, but I think my camera is not working. It won't allow me to turn back on.
Oh, no.
But it doesn't matter. I can just talk it through. Or it does. How is everybody going? Like, we can cover this on Saturday if you prefer. If you're like electrotherapy out, like if you want to let us know in the chat, whatever you feel like. How are we doing for time?
The 1 hour 14 in.
Okay.
So you have got time if people want to do it.
Yep. Okay, so we'll do a little bit of it anyways. I don't think anybody has said no. Okay, so move on a little bit now. Okay, so this goes back to like our basic physio school stuff. Now, I know in my undergrad we did not do a lot of electrotherapy by any means, but I think we all know who Professor Tim Watson is. He's like the electrotherapy guy. And he has a really useful website, electrotherapy.org, that he kind of continually keeps updated. It's very, very current and up to date from what I can gather. But the electromuscular stimulation part of maple is basically passing an electrical current through the motor unit, which is the efferent, and sensory nerves, which is the afferent, in order to artificially activate the muscle fibers to increase independent activation, leading to increased movement, bulk, power, and confidence. There's also a pain easing from muscle overactivity or smooth muscle irritation. So we have like the strengthening, but we also have the down training side of things, which is great. There's a long kind of quote there from Tim Watson, but I don't need to read that out. If you want to move on to the next one, Niall. Okay, so of course, with anything that we use internally with our patients, there's contraindications and precautions. So certainly pregnancy will be the biggest one, particularly when we're dealing with, obviously when we're dealing with women. I've had a patient who I was about to start maple with, and it's a lesson learned to me. I was like, is there any chance at all you could be pregnant? And she was like, no, I don't think so. She's like, my period's a day late, but no, I don't think so. And I was like, oh, you know, you have to go with your gut instinct a lot of the time. I was like, no, I'm not prepared to risk it. And lo and behold, I got a message 6 weeks later going, surprise. So we have to be very careful with like our consent and, you know, our screening of our patients before we go in and use anything like this. Also malignancy, if there's any kind of issues pelvic wise, if they have a sacro neuromodulator in, if they have a pacemaker, because we're bringing electricity into their body, so we don't want to upscuttle anything like that. If they have any psychogenic pain, if they have any severe skin or tissue conditions, particularly around the perineal area, vagina, anus, just from a comfort perspective more so. If they have severe atrophic vaginitis, also like from a cognitive perspective, if they have the inability to understand or tolerate the treatment or kind of understand what we are doing and why we're doing it. Excessive vaginal bleeding, especially unexplained or postmenopausal. I have done maple treatments on women who have their period. I have a lady who's trying for a baby at the moment, and what we're doing, I kind of what we figured out is that I will do a treatment the week of her period and before ovulation, and then we kind of down tools for a couple of weeks, and then if her period comes back, we go back in again. Precautions wise, immediately postpartum, I suppose I'll never forget it when the day I was leaving the hospital after I had my little girl, I remember the midwife saying to me, absolutely nothing in your vagina for 6 weeks. So the maple probe would fall into that category. Poor skin condition, reduced sensation. So I'm sure you've all had EMS treatments or like practiced it, you know, there is like a tingle to it, or like that kind of pins and needles kind of sensation. Now, not everyone feels that, depending on how sensitive they are down below, but if they have reduced sensation, it's a precaution. A previous malignancy, a body piercing in that area, if they have an IUD, hemophilia, epilepsy, sexual abuse, I suppose you would have that screened thoroughly beforehand, before you'd even consider doing your vaginal examination, never mind introducing a probe. Vaginal bleeding, and then reluctance or fear of the patient. But you can get all of those on that link that is there. You know, it's a brilliant assessment tool, it's a brilliant treatment tool, but like anything, it's not for everyone, but it is for most people. They do find it very, very beneficial. You can move on now. Okay, so we are looking at skeletal muscle fibers. So we said that before, you're not picking up smooth muscle with this, it's always skeletal. And we're looking at the alpha beta type 2 touch, the alpha delta type 3, which picks up your temperature, pressure and pain, and then your C fibers, which are your type 4 chronic pain. So your type 2 alpha or type 2 beta are more so your fast twitch fibers. And then your slow twitch fibers are more your type 1s. So we always kind of explain that your fast twitch fibers are more like your sprinters or your like Usain Bolts, and then your marathon runners are more like your, for the Irish people, the Sonia O'Sullivans, and for the English people, the Mo Farah kind of type runners. We know that the fast twitch fibers have a lower blood supply than the fast twitch fibers. and that they fatigue really, really quickly, whereas you get more endurance from the slow twitch. There's a lower number of capillaries, a lower number of mitochondria in the fast twitch than there is in the slow twitch. So they're two very, very different types of muscle, albeit that they're still skeletal muscle fibers. Okay, Noel? So again, NovaQuire gives you these beautiful handouts, which are really, really handy to have with all your parameters. So once you have done your assessments, you've got your images back and you've kind of clinically assessed it out the way that Gillian had described with her case studies, you then have to go in and decide, well, do I want to work on reducing the activity in a muscle? Do I want to work on increasing the activity in the muscle? Do I want to look more at the dysfunction that the person is coming in with? So when you have the app open, you can go into the person's profile and it gives you these options. So you can look at underactivity, overactivity. You can look at overactivity and contractions or continuous. You have urgency, frequency, pain, high frequency, pain, low frequency. So this is where I must admit, it boggles my mind a little bit as to which parameters I want to choose. And I know at the training days we had with Meryl, her electrotherapy knowledge was unbelievable, and she was able to really clinically reason out why we would choose each parameter. So far, I've been using exactly what's been pre-programmed into the device. But they just basically tell you there. So it's like any of the other kind of electrical EMS machines that we would have used previously, where they have a phase duration, a pulse frequency, your fade in, fade out, all that sort of stuff. But what you do then is you set it up for the elements of the pelvic floor that you want to work on. And that's the beauty of having the probe, that you can switch parts of it on and switch parts of it off. Is there anything else you want to say about that, Gillian? I feel like there's more to be said about it. Oh, you're on mute.
There's one program on there that you can tweak to act as a kickstarter for a pelvic floor that just doesn't want to activate, and maybe the patient is really disconnected from their pelvic floor as well. So if you look at the bottom of that table, the pain low frequency options, so you've got a phase duration of 400 microseconds and a pulse frequency of 2 hertz. If you go into that program and you increase the phase duration to 1,000 microseconds and keep it at 2 hertz for a minimum of 10 minutes, it's continuous. Quite often what I found, and I think what a lot of people who are trained by NovaCare have found, that is a bit of a kickstarter or CPR for a pelvic floor that's really disconnected and really inactive. And that can be a useful tool to, if you've found, say, a very pale grey summary on all 3 of your grids, so the rest grid, the MVC and the endurance are all looking pretty inactive, then using 1,000 microseconds with 2 hertz on a continuous setting for 10 minutes, and then going back in and retesting, quite often you'll see, oh, those muscles have come back in and the sensitivity for the patient is increased as well, and they just feel more connected. And that gives you an ability to maybe choose a different parameter for electrical stimulation, or maybe even going on to biofeedback training. But that is another program that's not on there, but I think it might be in the updated app at some point in the future.
Yeah. And I suppose just that blue box at the bottom as well, the warning about the possible side effects. You know, we're going in and doing, even though the patient might not feel like there's very much happening to their pelvic floor, we're going in and maybe doing a 15-minute treatment or a 20-minute treatment or 2 15-minute treatments. So there's been a lot of changes happening to the pelvic floor in that time in a person who probably didn't do very much with their pelvic floor before that. So I do explain to them that progress is not linear, and that things may potentially get a little bit worse before they get better. I've had one patient and she's like, I am exhausted every day after I have treatment. Like, it really floors them. And she's like, I'm often wondering, like, do you even have the thing turned on? You know, because she can't feel it, but she does be floored energy wise afterwards. So just giving them that little bit of caution is really advisable as well, so that they're not coming back to you going, oh my God, what have you done? It's more just that they're aware that things aren't, you're not waving a magic wand essentially. So yeah, you can move on, Niall. Okay, so when we look at treating muscle dysfunction, if we are looking at fast twitch fibers, we look at kind of a frequency of 50 to 80 hertz and a phase duration of 200 to 400 microseconds. Whereas if it's more the slow twitch, it's different. We look at a frequency of 35 to 50 hertz and a phase duration of 200 to 400 or possibly 600 microseconds. But they're pre-programmed into the Maple itself. But I suppose this goes back to then your assessment. What have you looked at on your assessment? What does the line graph show? Have you isolated the correct muscles to give you a clear picture of what's going on, to then reason back, like, is the patient telling you that they have symptoms that are more fast twitch fiber related or slow twitch fiber related, and then you choose your treatment parameters based on that. So you can move on now. Okay, then I really love this about the Maple, like the pain element of it. I think it's really, really important. So when we look at treating pain, there's the gate control theory. So that's where we stimulate type 2 alpha beta fibers to activate the inhibitory nerve fibers of pain in the dorsal horn of the spinal cord. So when we look at the parameters that are kind of optimum to that, if it's a frequency of 80 to 100 hertz, and the phase duration is 80 to 200 microseconds, and it's 15 to 30 minutes. Several times per day is allowed on a continuous OR cycle. Then if we're doing the endorphin release, this is what Gillian was talking about with regards to like the kickstart to your pelvic floor. So endorphins are secreted by the hypothalamus and the pituitary gland in response to a pain stimulus. So this is the one that you can tweak. So for the endorphin release, the frequency is 2 to 4 hertz and the phase duration is 400 microseconds. And the intensity is increased to the point where the patient feels a twitch, and it's on a continuous cycle. But that's the one that you can alter yourself to bring it up to 1,000 microseconds, but leave it on the 2 to 4 hertz for that kickstarter, that kind of CPR to the pelvic floor. So I have a patient that really was suffering with really, really severe dyspareunia, and you know, of course, it got to that stage where she was really desperate to have a baby, but she just did not want to go down the road of fertility or anything like that. She just felt her, you know, her journey to become pregnant should be through having intercourse with her husband, and she has done so well with it. It's brilliant, like the difference that it made, and in quite a short space of time. I was surprised. It's been fantastic. Okay, Niall, you can pop on. That YouTube thing probably won't play. Okay, so go back. Okay, perfect. So if we're looking at treating like overactivity and urgency in the bladder, then this is another function that we can use the EMS to treat. So smooth muscle sensory treatments for the bladder are on the following settings. And I know we were saying before that it's skeletal muscle that we pick up on the measurement side of things, but there's a slight tweak that you can make to how you position the probe and the parameters that you put in to really get a good outcome for patients with overactivity. So the frequency on this one is 8 hertz. The phase duration is 1,000 microseconds. Duration is 20 to 30 minutes. And the plates are the anterior and left with a quarter turn of the probe to the right. I find that really hard to visualize just talking about it, but we can go through that on Saturday to show people what we mean. I must admit I haven't used this on any of my patients, but I'm sure Gillian has, and we can go through it a little bit more on Saturday. But just to know that there is that option available for treatment. Is there anything you want to say about that, Gillian?
Not really. It's basically that on EMG you won't be able to target smooth muscles, but on electrical stimulation you can at those settings. And this treatment is direct to the bladder wall and the urethra because of the movement of the probe, that quarter turn. It's a similar treatment to PTNS or TTNS, but it's direct to the bladder, and it would be 20 minutes per treatment. But again, that would need to be done in clinic. But if you have got someone who's got overactive bladder, it is really useful. I use it on a few clients who are still on the waiting list for PTNS, and that's something that they found really useful.
Brilliant. How often would you do that with them, Gillian?
Once a week.
Once a week.
And I quite often will put them onto a home unit. So there isn't a home unit for Maple at the moment, although that is in production as far as I know, or in R&D anyway. We can talk to Onno more about that on Saturday. But I would use like a NeuroTrack or a Kegel8 or something and do TTNS with them every day at home, and then they would come into clinic once a week if they can travel that far. Quite a lot of my clients travel quite a long way, so if they can't come in weekly, then they would come in fortnightly for a 20 to 30 minute bladder treatment with Maple.
Perfect. Okay. So it's nice as well that you can, we have adjuncts for the patient to use at home while we do this in clinic. It's nice that it's not just you have to do this and only this.
Yeah.
Cool. Okay, you can move on, Niall. How are we doing for time, guys? Are we doing okay? Okay, so this is just basically a summary of what I went through there. So you can pop on through, but you'll get all these in the handbook with the Maple. So the current then is, I suppose basically if the person can feel the tingles, it's basically how strong the tingles feel to them in layperson speak to the patient. But what we're actually looking at is the current. So you have your 24 small electrodes, and the current runs from 0 to 29 milliamps in each electrode. But because Ohm's law says the size of electrical current varies directly with voltage and inversely with the resistance within the circuit, the max current allowable is 29 milliamps to avoid a max peak of intensity if the resistance drops. So like if the person moves or if the contact is reduced, you can get that shoot of high peak, and it can be uncomfortable or painful. I had a patient who I suppose experienced this a little bit. We had it up, we were working, it was an anal insertion, and the patient was like, oh my God, I just have to pass wind, I just have to. And with the air like passing by, it was like a big kind of intense feeling from them when the probe was working. So there's a reason why there is a max placed on the probe, I suppose, and within the app itself. I suppose it's basically comes down to do no harm, so we want to have that kind of risk managed well. Not that it's a risk, but we just don't want to encourage the any kind of discomfort or pain for the patient. And there's a paper there on that if you want to read it. Okay, Niall, you can pop on. So then we have the fades. So the fade in is the duration of time to reach the peak current. So the longer it is, the less noticeable it is and more comfortable. So it's just that gradual onset. And then the fade out is the duration of time to reach 0 milliamps. And the shorter it is, the more noticeable the drop is, and there's an increased sensory awareness. So for patients, it's not comfortable for them if it's like on off, on off, on off. It's quite intense for them, and it's much nicer and more comfortable if it just gradually fades up. It's there at a current for a prolonged period of time, and then it fades off again. And I go by what the patient tells me they can feel, what they feel is tolerable. I'd say to them, like, don't like suck it up and grin and bear it and just tolerate it. It's more about comfort levels, and that it does change with every treatment as well. Like I find for women, they might tolerate more current, like going up the milliamps, depending on where they are in their cycle, what position they're in, if they've had a bowel movement, all those sorts of things. So you can pop on again, Niall. Okay, so this just is kind of a recap really of what we talked about before. So when you pop your electrode in, we're thinking about the area that we're going in, so whether it's vaginal or anal, and then we're looking at what muscles we want to work on, and then we want to decide what treatment parameter we're going to use. So what we could do, there's like 4 options. So there's ring to ring, which is basically you pick a ring between 1, 2, 3, 4, 5, 6, and that uses the rings all the way around the 4 quadrants. And you'll only have 2 on at the same time. And I think, Gillian will correct me if I'm wrong, you can only have 1 gap in between. So you could have 1 and 3 or 3 and 5, but you couldn't have like 1 and 6.
Yeah.
Because it's to do with how everything conducts around between itself. You could do side to side, so you can have anterior to posterior, or anterior to left, anterior to right. You could do side to side, which would be on, off, on, off, on, off on 2 parts. Or you could do side to side, 3 to 3, where 3 rings are on in 2 quadrants and 3 rings are off in 2 quadrants. I think that's right. Gillian will explain that better, because that can get quite confusing.
But this is something that is going to come to life on Saturday. Yeah. We're trying it. There is another slide which shows how the electrodes communicate with each other. So I don't know, it might be the next slide, Niall, if you want to.
I think it is.
There we are. So you can see there, the most common setting that I use is ring to ring. So as an example with ring to ring, if you want to focus on puborectalis, you would choose rings 3 and 4, and you would be able to stimulate exactly to puborectalis. So for instance, if you've got someone who's had a forceps delivery with an episiotomy and the puborectalis is a little bit switched off and disconnected and not as active as it should be, not responding to the patient's request to squeeze, then you can use the stimulation rings 3 and 4, and that will specifically target puborectalis. If you, on the flip side, then if you've got puborectalis anally that is overactive, you could still have ring to ring 3 and 4, but you would use different electrical stimulation parameters to down train and reduce the activity in that muscle. So there's a few steps that you need to go through in terms of what's the patient's problem, what have I seen on EMG testing, and then what do I need to do? Do I need to increase the activity, decrease the activity? Do I need to target pain and reduce the pain response or the pain, the feedback? So with ring to ring, you can be specific to a muscle. You could use rings 5 and 6 anally to focus on the external sphincter. And then you can see here where the red circles are, where you would be accessing the muscle. So if you want to do the whole pelvic floor, so that like that Kickstarter CPR setting, the 1002, you could put it on the side to side and you can see the red circles there. It would communicate with the whole pelvic floor. So you've just got to get used to what these are. And as with the pictures of what the grid means for which muscle, the locations of the muscle, we've got them printed out and laminated. You could have this printed out and laminated, A4 or A5, whatever you prefer. And the more you check it and the more you work on it with your clinical reasoning, the more you get to understand which will work best for you. I think that helps. Is that okay, Suzanne? You there, Suzanne? Niall, are you there? If you want to go to the next slide. That's great. I'm not sure if Suzanne can hear you. Suzanne's muted, but I'll carry on until Suzanne comes back in. Hopefully everybody else can. Oh, it says there you can't unmute. So Suzanne can't unmute. I don't know whether you want to help with that, Niall. If I mute, are you able to unmute, Suzanne? Oh, no. Okay, no exclamation mark. Okay, so I'll carry on. Hopefully, if Niall, you can help Suzanne. And once you're unmuted, Suzanne, if you jump in, but I'll carry on just to make sure we can get through everything. So in terms of troubleshooting, if you've got any problems with Maple in terms of electrical stimulation, if you get any error codes, it's worthwhile looking at the following things. So have you used enough gel? Have you got enough contact? So remember, the electrode gel acts as a contact between the muscle and the probe. So you need to have a good amount of gel on there. You also need to think about the position of the probe. So for instance, if your patient is feeling that's too uncomfortable, then you might find that, well, maybe the probe is being twisted or pulled into one direction, or maybe the probe is resting too closely to one side. You can try and centralize it. Also, if you have a patient that can't feel the stimulation, then the best thing to do is to start off by increasing the phase duration, the microseconds, because as you increase gradually the phase duration and try the stimulation again, they should be able to feel it a little bit more. But if it's too uncomfortable, then you need to reduce the phase duration and lower that so that it's not as sensitive. So you can troubleshoot with that, and we will practice that on Saturday. If, for instance, the muscle activation, you want to work on the slow fibers, you've got to make sure you're in the right frequency range. So if you're in the wrong frequency range, then you should find that the muscle activation won't happen. And the ideal is to get artificial exercise. So it's important that you have the right frequency. So getting used to using the NovaCare protocols will be really useful for that. And sometimes then you just need to switch the electrodes if you're not getting what you need. Okay, I think Suzanne's had to leave, and hopefully she'll come back in. So now if we can go to the next slide. Okay, so time-wise, we've got 15 minutes, so I'll do some of these clinical discussions. So first of all, we've got Maple and stress incontinence again. And you can see here that we've got a lady aged 42, and her main problem is stress incontinence when exercising, and she wants to return to running. So what we have here is a very inactive pelvic floor. So we're looking at MVC. And you can see on the grid, there's no real dark colours, dark shading to any of the segments on the grid. And you can see that her blue line on the graph is not lifting very high at all. The first one was good, and then she fatigued very, very quickly. So I think if you click to the next slide, it might bring some more information on. There we go. Okay. So what we're going to be doing for this lady is we're going to focus on the fast twitch, because for stress incontinence, you want the fast twitch, and also on our MVC findings, her fast twitch muscles are not functioning as well as they should. So to get the fast twitch muscle fibers working, we're going to use electrical stimulation with a phase duration of 250 to 500 microseconds. Now, what you could do when you first use your Maple is have the handbook in front of you with the stimulation protocols, or like Suzanne has said, you can use the protocols that are on your iPad on the Maple app and start off with the standard NovaCare settings that you have on your iPad. And then you can start tweaking depending on your patient and your own experience. But as a standard, we'd use 250 to 500 microseconds phase duration for this patient, and 50 to 80 hertz frequency. The frequency, I probably, for fast fiber, I wouldn't go as low as 50, because at 50, you've got a little bit of overlap with slow fiber activation. So I would probably go for the 70 to 80 hertz for the frequency. And then for the microseconds, you might need to start stimulation, see what the sensitivity is like, and then come back. So if their sensitivity is low and they can't feel it, then go out of the stimulation, increase the phase duration, and then go back in and see if the sensitivity is better. Because remember, with stimulation, we're not just artificially exercising the muscle, we're also exercising the brain to body connection. So you want to make sure that that patient can feel the movement, and you want to get up to a level where they can tolerate a high enough level of stimulation that they feel the movement, but not such a high sensitivity that it becomes painful. So it is a bit of a balancing act, and you get to know your patient, you get to know the problem, and you get to know your stimulation parameters as well. In terms of which rings and plates, it's a little bit unclear because the whole pelvic floor needs a good workout. So we could do side to side, right and left, and that would cover the whole. Or we could focus in on puborectalis, because that will give a lot of your continence mechanism for reducing stress incontinence, and maybe do rings 2 to 4. So ring 3 would be brought into that. So that kind of would be up to you and your own clinical reasoning, but I would probably start with puborectalis. That will help with the continence mechanism, but it'll also help that when that starts to activate, the patient then will feel the elevation, and you can start doing some pelvic floor training independently at home, either side of the maple treatments. I don't know whether you wanted to add anything to that, Suzanne.
Nope, that sounds good.
Yep. Thank you. Let's go to next slide, please. And for those of you who are feeling really tired, we are almost there now, just 10 minutes. So this is maple and prolapse. So this is a lady who is age 56. She has a stage 2 anterior wall vaginal prolapse, and she also has deep dyspareunia. So we're looking on the grid and the line graph. This is just a screenshot of the endurance work. And you can see here that with the endurance, she has a little bit of endurance, then it fades off. Then she rallies again, and then it fades off, and then she finishes with a moment of glory before that grey box finishes. Now, what's really important is to see where this screenshot was taken, because looking at the pelvic floor there in the grid, you would think that's not very active, and it doesn't seem to tie in with that grey box. But what you can see is the end of the blue line is actually in the rest section. So the very last bit of the blue line is in the white section. So that screenshot has been taken when the muscle is at rest. Okay, so what we're seeing here is basically what ties in with that deep dyspareunia. And you can see ring 1 posteriorly and ring 1 on the right. Oh, we got a question there. Okay, yeah, so that's questions we can ask on Saturday. I'll write it down and make sure it's covered on Saturday. So with the resting activity, we can see that coccygeus is overactive at rest, and that could be something to treat. But we can also see from the line graph that there is poor endurance. She can hold a squeeze for a short amount of time and then it fades, and then she holds again and then it fades again. So Niall, if we go to, it's not the next slide, but the next bit of information on that slide, it'll tell us what we want to do. So we're going to use electrical stimulation for this lady, but we might need to do 2 different sets of electrical stimulation. So first of all, we've got to work on the activity of the slow fibers. So to get the slow fibers to improve her ability to hold and to support the pelvic organs, we're looking at 250 to 500 microseconds for phase duration. Depending on her sensitivity level. So higher if she's less sensitive, lower if she's feeling discomfort. And then 35 to 50 hertz frequency again. But again, I'd probably keep lower at the 35 to be definitely working the slow fibers, because if you're coming up to the 50, then you're going to be overlapping with the fast fiber work. In terms of rings and plates, again, it's unclear. So for the electrical stimulation to reduce the activity of coccygeus, we would probably do rings 1 and 2, and we would do a slightly different setting. You'd probably do the pain relief or down training setting for that. But for the activation part of it, we don't really know, because we haven't seen the grid for that. But I would probably, again, do rings 4 to 6 to increase the superficial closure So rings 4 to 6 are more the superficial muscles. And if you can get that sensation of vaginal closure as a starting point for treatment, then you'll probably find that the sensation of prolapse will reduce. So that's a good place to start for someone who is struggling with prolapse symptoms. Did you want to add anything?
No, just that from the day that in Cardiff with you, I really found that, you know, getting that feeling of closure, working on the outer rings has helped a few of my patients hugely with that feeling of something coming down. It's really beneficial for them. And it probably wouldn't have been the first thing I thought of prior to doing the training with you.
Sure.
So like what I would say is definitely, if you do invest in this, like learning from everybody is really important, because I'm definitely novice with this yet, but like everyone has like their own little tweaks and tips to use.
Yeah.
So yeah, having that conversation with all the other people that are using it is really important.
Yeah, and I think going through case studies is really important like this. And I think having regular times where you can share case studies, whether it's, I don't know, on a WhatsApp group or a Zoom call or Microsoft Teams call, on a fairly regular basis can be really useful in building confidence, but also finding out those little tips and tricks that can be really helpful.
Yeah.
Yeah, good. Okay. So now if we can go to the next slide. Almost there. So this is anal. So anal insertion of the probe, and we are looking at a lady aged 76 with fecal urgency and difficulty getting clean after a bowel movement. So with fecal urgency, we might be looking at an underactive puborectalis, underactive external anal sphincter, and then difficulty getting clean after a bowel movement, we might be looking at an underactive external anal sphincter. So we've got two grids there. They're both MVC, so maximum voluntary contraction. On the left, you are looking at the whole pelvic floor and anal sphincter complex. And on the right, you're looking at just ring 6. And we're looking just then at the anal sphincter. And you can see then on the peak EMG, when you're looking at the whole pelvic floor and sphincter, it gets to 30.5 microvolts as a peak, which is actually pretty strong. But when you look at the grid, you can see all of that activity is coming from the central parts. So from 3, 2, and 1, a little bit of 4 as well. But rings 5 and 6 are fairly inactive. And then if we then look at filtering out and looking just at the external sphincter, you can then see the peak score for just the ring 6 is as low as 9.9. So she's been asked to do the same squeezes, but we've just zoomed in and looked at the external sphincter. And what that's shown us is there's quite a difference when we're looking at the pelvic floor included with the sphincter compared to the sphincter on its own. And we can then highlight that the sphincter is less active and possibly dysfunctional. Whereas puborectalis, on the left-hand grid, is actually looking fairly functional, although on the left-hand side, rings 3 and 4, 3 is looking good, 4 is not so good. So there might be a slight dysfunction on the left puborectalis, but the major issue is the underactivity when squeezing the external anal sphincter. Now, the the graph that you can see there is the squeezing of the external anal sphincter, so the second grid. And you can see there that it's not getting above 10 very often. So that would be what we wanted to try and increase. We want to see darker grey in the outer circle and higher blue lines if we're just looking at ring 6. So for treatment then, Niall, if you go to the next bit of information on this slide. So we're going to use electrical stimulation, and we're going to focus on fast twitch initially, but then also build on to slow twitch. But once we've got the fast twitch, then the patient is able to feel the movement and isolate the anal sphincter and start to do her own exercises. And then we can add in slow fiber with maple until she's able to do that more effectively with the anal sphincter. And then she can add that into her home program. So with the anal insertion of the probe, we will use the parameters 250 to 500 microseconds of a phase duration, probably closer to 500 microseconds if she can tolerate it. And then we're probably going to go on the 70 to 80 hertz, because remember the 50 is kind of overlapping with slow fiber. So we want to keep it clear to the fast fiber. And we would use rings 5 and 6 to make sure that we get external anal sphincter activation. You have to have 2 rings activated. You can't have just one. So we would go for 5 and 6. We know that we can't be definite with ring 5 what is external anal sphincter and what's internal anal sphincter. So activating rings 5 and 6 when you've got an underactive sphincter is the best way to go. So hopefully that makes sense. And then if we go to the next slide, I think we've got one last slide on pain. So yeah, this lady is female, age 52. She's chronic pelvic pain. She does have a diagnosis of autism. So if we go back to what Suzanne said, one of the precautions or contraindications is not being able to understand commands. Now, I made a decision that this lady's pain meant that she would benefit more from treatment in clinic with my close guidance than dealing with the pain, and any sort of internal examination vaginally was causing too much pain, whereas if the maple probe was sitting there and she was having electrical stimulation, it was something that she could tolerate and it was effective in reducing her pain. So we went with that, even though her diagnosis of autism meant that she was struggling to follow commands, but we did it as a very sort of we're just going to do this treatment for you, and then once the pain is reduced, then we can start doing manual therapy and your own home exercises as well. So that kind of is something that just to note there. So we've got the grid there. We've got rest, MVC and endurance on the grid. And you can see on the left-hand grid, the resting activity is high in coccygeus on the left specifically. So on the left there, ring 1 and into 2. So you've got the dark shading there, and then a little bit down into posterior ring 1, but that may well be less of an issue. When she's activating the muscles in MVC and endurance, you can see again, it starts really at coccygeus on the left. So rings 1 and 2, and then into 3, and then posteriorly rings 1 and 2. But the rest of the pelvic floor isn't showing a huge amount of activity. So there's quite a lot of asymmetry there. And potentially she's overusing that coccygeus muscle because it's able to work, but then it's not able to let go. And that is giving her the deep left pain that she's experiencing. So if we go to the next bit of the slide. So we're using electrical stimulation for pain relief. We've got 2 options. We've got the high frequency and the low frequency. It doesn't particularly matter which one you try, but if you try the gate control theory, the high frequency, and the patient is unable to tolerate it in terms of sensitivity, especially when their pain is very high, I would usually always start on the low frequency, and then once that's brought the activity down and it's brought the pain down, then you're more able to work with the gate control theory. So it's worth looking into that. So I start with the thalamus and then move on to gate control. And for her, I've kept with rings 1 to 3 on a continuous setting. And it did, I haven't got the information on the slides, but it did bring her muscle activity right down, and it also brought her pain right down. So she's now pain-free, but has ongoing symptoms with an overactive bladder, which we're treating separately with bladder training, etc. So it was quite effective. Within about 2 treatments, her pain was eased. So I think those are all of the case studies. I'll bring my iPad with me as well on Saturday, and I've got a few cases on there if people want to speak to me separately. And it's 1 hour 59, which is pretty amazing, isn't it?
Spot on.
We said 2 hours, didn't we? So yeah, there's a few people coming up on Q&A and chat. So maybe if you bring your questions to Saturday, and we've got a question on rings as accurate in standing as in lying. Yes, they are. And can you use it to test functionally? Yeah, so we can go through different positioning and maybe try standing on Saturday as well. Don't know if Suzanne's still there.
Oh
no,
no.
can
you hear me?
Yeah.
Okay. Yeah. I think one of the papers looked at like the maple and Pilates positioning and stuff. So yeah, it's definitely something we can play around with.
Yeah. So I've started using maple in standing with a few of my clients. We quite often will put their undies on as well, and the wire will come out the side of their undies, and then there's a lanyard to hold on to it. And also I've started to do it with stepping, standing on one leg, clock face lunges as well. It does tend to slip a little bit, so it would be great to chat to Onno on Saturday about options for like having something that would hold the probe in place, because we want to keep the validity, but we're just playing in our clinic a little bit, but it is showing different uses there, which is quite interesting. Thank you for the thanks as well. There's lots of nice messages on there. Thank you.
I think, ladies, that's everything. Suzanne, Gillian, that is absolutely brilliant. Thank you both very much. I hope everyone's found it useful. I look forward to meeting everybody in person. The technology shouldn't be a problem because we'll be all live. If there's any queries about how to get the Portlaoise is easy to get. Anyone who has any issues about getting the directions to the B Braun clinic, give me a phone call on the mobile. If Google Maps will find it very easily. If you go to the turn off for Portlaoise, you'll be led there. I hope everyone's found it useful. I think everyone probably wants to have a cup of tea now and digest.
Thanks, Niall.
Yeah,
thanks,
thank you.
Gillian.
I don't know if you can hear me. Thanks, Niall. And thanks for everyone for giving up their time. Thank you for the help, Gillian, and stepping in.
No problem at all. I'm looking forward to seeing everybody on Saturday. See you there.
You too. Okay, see you Saturday.
Brilliant.